Okay, so welcome everyone on board. So let's have a look on this scenario. So there are so many books with these sort of scenarios, and if you just want to uh, get maximum out of these books or these scenarios, you just have to because all these books are practice books. Okay, so like if I want to extract the task or goals for revision, or you can say understanding, or you practice. I will be looking at this scenario. So there is a 70-year-old male. So one point will be 70 and old, and then this is post-op patient of elective abdominal aortic aneurysm repair. Okay, whether maybe it is open or endovascular. So these 2 points, and then there is history of hypertension, there is history of ischemic heart disease. Okay, so next point will be that there are three medications. So it's statins, enalapril, that is ACE inhibitors, atenolol, and aspirin. Okay, then the patient is a smoker, and they have mentioned it 6 months ago. Uh, he has stopped it. Okay, so um, this is the data which you have, and now we have to just expand. So on next point, what they have written, that there was around 1.2 liters with an aortic cross clamp time of 65 minutes. Okay, and then urine output during the intraoperative period was around 90 ml per hour. So you can say it's more than adequate amount of urine. Well, if the patient is around, even for example, uh, 90 kg, so it's around 1 ml per kg per hour. So just you need to just have a look on the effects of aortic clamping and cross clamping and release, and these things you need to remember. Then this is challenges in post-operative period. Okay, you can say either it is PACU or um, HDU or ICU. Okay, so then this patient has epidural, and the patient is receiving 0.125% bupivacaine and fentanyl. Okay, so we will just try to extract what we can from this scenario. So this, he was weaned off the ventilator and extubated 4 hours ago. So up till now, if you just try to think, so um, there are so many things which you can have. Like for example, can anyone tell what are the um, side effects of uh, intrathecal or epidural fentanyl? Anyone can tell?
Respiratory depression,
Okay.
itching.
Pruritus, yes, itching, pruritus. So if it happens, what will you do?
We can change the opioid infusion without the fentanyl, and we can use only.
Okay, at that time, you have to give naloxone or the normal antihistaminic, which will affect
Naloxone.
naloxone. Okay. Okay. So similarly, um, can anyone tell what are the anesthesia concerned with simvastatin? If the patient is taking simvastatin, what possibly can you find in that patient?
So myopathy is that?
Myopathy is, yes. Myopathy is like liver dysfunctions. Okay, there may be some raise liver enzymes. Similarly, enalapril, like it's ACE inhibitor. So what side effect the patient can have with reference to anesthesia?
Patient has uh, introp hypotension, refractory.
This is one thing.
They
What
they
else?
can have electrolyte abnormalities as well.
Like
I think hypokalemia,
it's related to hyperkalemia
okay,
Hyperkalemia.
and
hyperkalemia.
and angioedema, dry cough. More, it's AC inhibitor. Can you tell me why there is dry cough for OS with enalapril?
So because of bradykinin is there, that is not getting
Why?
pathway. There is a more this the synthesis of this bradykinin.
Not synthesis. Be
So
specific.
actually,
Not
uh,
synthesis.
that is excretion. That's
No, not
metabolism.
excretion. Not excretion, not metabolism. Use
No,
the correct
no,
word.
no.
Use the correct word. Acinine enzyme is also breakdown, is breaking down
Brad,
bradykinin. So if
bradykinin.
AC inhibitors you are giving, so there will be excessive bradykinin. So it is related to this dry cough. Okay. So atenolol, what are so both these medication, enalapril as well as atenolol, they can cause hyperkalemia. Okay. So you can expect similarly like um, uh, aspirin usually 75 milligram OD dose is not associated much with much of the problems, but still, can you just think what can be the problems associated with aspirin?
Bleeding,
And bleeding.
Bleeding, asthma, what else?
bronchoconstriction,
Yes, this as bronchoconstriction, asthma, uh,
Kidney,
kidney
renal
dysfunction.
impairment.
Renal impairment,
kidney
not
disease.
in actually, this is just a brain exercise which we are doing.
Yeah.
Okay. So 20 to 30 cigarettes per day means it's around 1.5 pack years, 1.5 pack per day. So if he is taking for 30 years, so it will be 45 pack. Okay. One pack per day for 20 years is 20 pack year. So if he's taking around 30 cigarettes, so it's like you can say it's 45, like 1.5 pack. It will be more than one pack year. Okay. So it will become like 45 pack years. Similarly, 1.2 liters of blood loss. So which category of this bleeding or shock you will consider this patient? There are four classes. So I think in adult it should be class 3 or class 4. I think it's class 3. 500 to ml to 1000, and then I think 1.1 to 1.5, and you can have a look on the classification on of shock. Let's okay. So this is class 2. It's around 1.5 liters is class 2, and then more than 1.5 to 2 is class 3, and more than 2 liters is class 4. So that's how you classify with reference to blood loss, and then the changes: heart rate, blood pressure, pulse pressure, respiratory rate, urine output, uh, like signs of poor peripheral circulation. Okay, and then CNS mental status. Usually in class 3 and class 4, you need to give blood. Another point is that it depends on the allowable blood loss. Okay, so you need to know how much is the initial hematocrit, how much is the last hematocrit, and you will be calculating how much will be the allowable blood loss. Okay, so okay, uh, these patients who are having this clamp, they are at risk of renal impairment. Okay, so how to maintain the renal perfusion in these scenario? Like like uh, what things come to your mind? Good perfusion, good good amount of fluid, good perfusion pressures of the kidney, and there is one medication which is being used sometimes, though I am not sure how many people have used it. Do you remember the name of that medication which might be used?
Mannitol can also be used.
Mannitol will cause diuresis. Okay. What
Yeah.
else? There
Dopamine
are
can
actually
also be used.
dopamine, actually, dopixamine
Improve renal
is
blood flow.
one of them, and N-acetylcysteine. N-acetylcysteine is being used for renal protection, not only in this aortic cross clamping, but also in contrast-induced nephropathy. Okay. Um, what else? Okay, just let's have a look. During this clamping, what else you need to take care? Of course, there will be above the level of clamp, there will be sort of hypertension, and below the level of clamp, there will be hyperperfusion. Okay, so one thing at risk is kidney. What else? What else is at risk?
Liver.
The heart.
Liver.
No, no,
The
it's
liver.
spinal cord. It's spinal cord. Okay. Um, have you heard of? I'm not very good in pronunciating the name. The artery of Adam Quits, something like that. How, I don't know how you pronounce it. Okay, so in such scenarios, spinal cord perfusion can be hampered, and you need to do the evoke potentials. Okay, so you have to maintain the you have to monitor spinal cord perfusion through evoke potentials. Actually, majority of times now these procedures are being done endovascular, but still you need to know how it goes. Okay. Okay. So that's how you can just extract few of the things, in some of the thing that like hypertension. So hypertension is associated with microvascular and macrovascular complications. So you need to just have a look. You should be knowing how good is the control of blood pressure, what medications, some of them are mentioned, but you should be knowing what are the outcome of having prolonged hypertension. So, cerebral oxygen, this autoregulation curve may be shifted to the right in chronic hypertensive, especially if it's not controlled. So, in that scenario, and another thing is that whenever there is ischemic heart disease, that you have to rule out cerebral vascular disease. That's why when such patients are going for definitive procedure like cabbage, so a number of times these patients undergo carotid Doppler to see the carotid supplies as well. Okay. Because these patients, if cabbage, they are undergoing cabbage, they have to remain on the pump. So whenever a patient with ischemic heart disease is undergoing cabbage, so they definitely they monitor uh, they they just rule out cerebral vascular disease. Okay, because it can create a problem in the outcome. So this is another topic, how to improve the neurological outcome in patients undergoing cabbage. So this may be one of the reason to do off-pump cardiac surgery. Okay. Uh, Similarly, you should be knowing the different classes of hypertension. Okay, class 1, class 2, class 3. I always like forget with the numbers. Usually, I think 140 to 160 and 160 to 180 and more than 180. This is class 1, class 2, and class 3. 90 to 100, 100 to 110 and more than 110 for diastolic. So this is for classification of hypertension. Then ischemic heart disease, if someone just want you to classify or like you can say quantify how much is ischemic heart disease. So you classify or stratify according to a Canadian class. Okay, so it's 1, 2, 3, 4. Class 1, class 2, class 3, class 4. And actually, Canadian class of ischemic heart disease and New York Heart Association classification for heart failure, it's almost the same. One is with the chest pain and one is with the dyspnea, shortness of breath, quantifying the heart failure. So one is classified like mild, moderate, severe, like that. So exertion, no shortness of, no chest pain, with mild, with moderate, with severe. That's how you will be classifying the this um, what you say, this uh, ischemic heart disease. Okay, so this will be one of them. Then whenever there is ischemic heart disease or hypertension, other thing which will be or which can be there is presence of arrhythmias. Okay, other thing will be like there may be blocks. For example, it depends on which artery is involved. There are chances of bradyarrhythmias if the conducting system, which coronary usually predominantly supply the coronary, the conducting system.
Right coronary.
Right coronary, okay. So usually if it is involved, there may be bradyarrhythmias, heart blocks. So these patients may have some arrhythmias. If it is like you might find these patients with bradyarrhythmias, maybe pacemaker. So whenever you have such scenario, it should be in your mind, okay? Because of course the next step will be the data, the further data. This is we are all playing and doing mind exercise about from this data. Okay, we are just trying to have some mind exercise from this data. This is actually a very nice book. It's a structured oral examination, but like if you just try to explore and have real practice, you should need to explore each and every line and each and every word accordingly. Okay, can anyone tell me urine output monitoring? Is it in standard one, standard two monitoring, or no?
No, according to AGBI, it's not a standard monitor. Even ASA,
Okay.
it's not a standard monitor.
Yes.
But in
So
this
actually,
case, definitely.
yes, this is you. So whenever you are in an oral exam, you should be saying that in addition to standard one and standard two monitoring, you need to do urine output monitoring, or you need to, as I mentioned, that in this case you need to have evoke potentials with reference to prevention of this spinal cord injury. Okay, or a detection of spinal cord injury. So this is one of them, one of the monitoring which you need to do. Okay. Um, okay. So can we just think about what will be the anesthetic challenges in a 70-year-old patient? Yes.
70-year-old patients have multiple comorbidities. This is one challenge, and they are high risk of post-operative complications as well. Delirium is very high.
Okay. Comorbidities,
They might be on
post-op
multiple medications.
post-op complications, delirium. What else?
They might be very sensitive to the anesthetic, so reduced dosing is usually needed.
So
Is that
you can say
reduction,
careful,
titration
titrated,
of the
titrated doses. Okay. Plus, what extra monitoring you need to do here? Intra-arterial blood pressure monitoring. Okay. Because of now the reflexes are not good. Okay. So they may not be compensating the normal in the normal way. The change, the normal reflexes will not be as good as in young patients. So if you are giving pre-calculated doses, it can cause severe hypotension. Then
Positioning.
problem with, yeah, airway challenges.
Yeah, you will have no dentures, so it might be
No, so
difficult
mask
ventilation.
ventilation will be a problem. And there may be especially if there is of course the comorbidities will increase, but even then osteoarthritis itself can cause problem with normal laryngoscopy. Okay, so there may be challenging laryngoscopy, challenging mask ventilation. And what about desaturation? What happens to
Yeah,
FRC? Does it change?
FRC
Yes,
is reduced.
FRC remains normal. It's a closing capacity.
So, closing
Closing,
capacity.
it's the closing capacity which is affected. So maybe at normal tidal ventilation, a patient with these patient may have low PO2. Okay, it's not FRC does not change. It's the closing capacity which changes. So this is another thing. Then something very common, IV cannulation. Okay, IV cannulation may be problematic because of the like skin very sensitive. They easily you can easily have double puncture. So you can expect some problems with reference to this thing. Um, uh, what else? Delirium. Okay. So if you want to prevent delirium, what factors you need to avoid? You need to my best friend, oxygen, avoid hypoxia, avoid hypercarbia. Temperature will be very important. Okay, if this patient remain hypothermic, this will be a risk factor for delirium. Okay, if you want to compare between midazolam versus Presidex, which is better with reference to delirium? Huh?
the Presidex.
Why?
Because it does not induce no such as amnesia so much.
I'm
Right.
sorry, again, please.
That it is sedation resembles normal sleep.
This is bookish word. What else? What's why midazolam? Midazolam, apparently we are very happy. We are giving it to for the prevention of prevention of delirium. But you are saying
Respiratory depression.
uh, okay, respiratory depression is okay, one thing. What else? Actually, we are talking with reference to delirium. So just try to pinpoint why midazolam will have more chances of delirium as compared to Presidex. Actually, midazolam usually is short acting. Okay, so it's you can say if it's effect and you are giving in a smaller dose because you are expecting respiratory depression. So midazolam effect will suddenly finish, and it can actually cause sudden, you can say, rebound. Patient can be more aggressive. So that's why midazolam, if you are giving, it's very difficult to titrate the dose, the required dose in which you will prevent the delirium. If you will give more, patient will have respiratory depression. Okay, and especially if you have given combination of midazolam and opioids. So Presidex will, as Sumera mentioned, so it will have natural sleep pattern. So this is an important thing. And another thing, if the patient remain hypotensive, okay, hypotensive or hypovolemic, this is also uh, uh, factor for delirium. Okay, GA versus regional. So GA will have more chances. Regional will have relatively less chances. Another, actually, this is more so with the ICU patients, but if the patient is hard of hearing, their patient is having some hearing aids, or like uh, eyeglasses. Okay, so especially if the patient in regional anesthesia, you can keep these things if possible. So this will also have, you can say, a sort of, yeah, what is treatment for postoperative delirium? Yes, can you tell me what is the drug of choice for delirium, postoperative delirium? Actually, it's like always with so many things, prevention is better than cure. Okay, so if you are trying to prevent the delirium, it's better than treating. But so all these things which we are discussing, a good multimodal analgesia, good volume, good perfusion, good volume status, all these things will help in prevention. And if it happens, actually the drug of choice is haloperidol.
No, yeah, in ICU also we use haloperidol. Yes,
Okay,
that's you don't
so
see much common in vacuum.
yes, so haloperidol, what are the don'ts about haloperidol? In which patients or which things you should be careful?
QT prolongation it can
So
cause. So
any
you have
patient with
to.
arrhythmias, you may be uh, careful about it. Also, uh, what else? One more thing.
The dose of haloperidol, sir.
I don't remember. Sorry, it's around. I'm sorry, it's around 5 milligram ampule. So you always give either intramuscular or you give titrated doses. Okay. What I was saying, one more thing with reference to haloperidol, especially in old age patients. It's
Antipsychotic.
anti-dopaminergic. Okay. Yes, it is antipsychotic, but it is anti-dopaminergic. Okay. So it can precipitate. What is the name of that symptomatology? No,
Neurolepsy.
extrapyramidal symptoms. Okay. There is another medication which can also cause an extrapyramidal symptoms.
Metoclopramide.
Metoclopramide. There is one dopamine antagonist which is being used oral and does not cause cross blood-brain barrier. Do you know the name of that medication? So it can be given. It is, you can still use it even in patients with Parkinson's disease. You can
Domperidone.
use. Very good. It's domperidone.
Domperidone.
Okay. So metoclopramide both has central effects and peripheral effects. However, domperidone will also only have peripheral effects. So they actually increase the gastric emptying. And actually, there are dopamine receptors where they act. Okay. This is,
Sir,
yes,
sir, will the haloperidol will cause a respiratory depression or not in post-op?
haloperidol.
Yes,
Haloperidol,
sir.
I don't, uh, it can cause sedation, by the way. Okay. But I don't think so. It will be that severe sedation. Okay. But if you want to control the delirium, haloperidol is one of the with the choice. Okay.
Can we give it IV also or IM?
Actually, usually I have seen intramuscular. I have used IV as well, but usually it's used intramuscular. Okay. It's also being used for nausea. Okay. It is also for post-operative nausea. Haloperidol is also being used. Okay. So we just have browse our mind through this scenario, okay? And you see that's what is called as active learning. That's what is called as multidimensional learning. So we just have concentrated here, and we have find so many points. Can you tell me what's the difference between HDU and ICU?
HDU usually doesn't have a physician assigned,
No,
that's what
no, no.
happens in our center. ICU, you have
Uh,
one-on-one level of care. HDU, you have two nurses, one nurse is caring for two patients. Uh,
Actually, technically speaking, it's a little different. Can anyone try to answer this? Technically, its answer is a little bit different. Technically, actually, one organ system other than ventilation is HDU. Okay, and more than one organ system is ICU with ventilation. Like either only ventilation. Like example is that if the patient is having high inotropes or vasopressors, plus patient is on dialysis. Okay, so that will necessitate two organ system. Or if the patient, by the way, patient in HDU can have BiPAP, but not ventilation. Okay, so for ventilation, it's ICU. So actually, it's another word is level 2 and level 3 care, something like that. Like normal ward care is level 1, and this is level 2, and this is level 3. I'm not sure about this terminology of levels, but this is for sure what I know. That HDU does not have ventilation. Okay, mechanical ventilation. Okay. Uh, few words about complications in post anesthesia care unit. Okay, so just one, two, three. Just think about pain, one of them. Okay, bleeding, one of them. Hypoxia, one of them. Hypercarbia, hypercarbia, one of them. PONV, one of them. Delirium, one of them. Airway obstruction, one of them. What else?
Shivering.
Very good. Shivering or hypothermia. So whenever they hypotension,
Vomiting. No, nausea, vomiting.
Arrhythmias.
nausea, vomiting, I've written hypertension. So just you should be knowing what you will be doing. Whenever there is nausea, vomiting, you have to rule out hypertension. Okay, because in some conditions, if there is nausea, vomiting, it's a sign that there is hypotension and hypovolemia. Okay. Similarly, whenever there is hypertension, you need to see pain. So if there is pain, there may be tachycardia and hypertension. So you have to, and these are all correlated. Okay. If there is like airway obstruction, there may be some stridor. Okay, and there will be certain surgeries which will be prone to certain things. So like if PONV, like any surgery in which vagal stimulation is there or vestibular system is there, there will be more chances of PONV. If use of opioids is a risk factor, you female gender is a risk factor. Okay, so like you will be you should be thinking, because like this topic of PACU will not be written in every book in a nice way.
Mm.
So challenges or complications in PACU. Okay. So
Yeah,
another
arrhythmias is also common. I have
very
actually managed two patients with atrial fibrillation,
very good.
one with SVT in PACU.
Yes.
So it's
So
common.
fair enough. Fair enough. So actually, there may be a lot of complications, but you have to use your like critical thinking how to approach patient problems in PACU. Okay, because usually PACU is run by nurses, and you just have, yeah, another important point to prevent these things is proper handover. Okay, proper handover is very important here. You have to tell what medications you have already used and like what problems can be there. Especially similarly here, oxygen therapy is sometimes actually preventive for a lot of problems. Oxygen therapy is good for prevention of PONV in initial period. It will be also good for the wound healing. Like there are so many things which are interlinked. So challenges and problems in PACU. And arrhythmias also electrolyte uh, or acid base imbalance. Okay, especially if any surgery in which these things are okay. So let's move forward. So the data was that there was a post-op patient, old age patient with these medications and smoker, and he underwent this aortic surgery, and now in PACU, this is the data which we have. And now what is there? Patient is conscious, breathless, okay, sweaty and clammy. So whenever there is sweaty and clammy, it means poor signs of poor peripheral perfusion. Okay. So his peripheral oxygenation saturation is 94%. So remember one thing, saturation, especially if it is going towards this number, the patient can suddenly desaturate because this graph or this number above it is safe, but below this level, actually, this is not reliable number. So if you like uh, combine this breathlessness and low perfusion, saturation can suddenly fall. So this is very important. And then you will see how much oxygen FiO2 patient is receiving. So just tell me one thing, if you want to give more than 60% oxygen, what device you need to use for oxygen therapy?
An RBF.
Non rebreathing. And this is one thing. What else?
You
There
can
is
use
one
high flow nasal cannula.
high flow nasal cannula. Okay. There is another thing which was
Venturi
Venturi
before
mask.
mask.
Venturi
Venturi
mask.
mask.
Okay. Because high flow nasal cannula is not a common thing before this COVID dilemma. Okay. So, but Venturi and this non-rebreathing face mask with non-rebreathing valve with reservoir bag with non-rebreathing valve. Okay. Okay. So now next step. So on examining the chest, there is bilateral equal air entry with crackles at both bases. So crackles is telling that me crackles with sweaty and clammy, like it will occur more so in a
Heavy.
patient with the sorry
Yes, heart.
pulmonary edema and
Yes.
low cardiac output and low impaired left ventricular function. Am I right? This combination will be
Yes.
there in a patient with poor LV function. Okay. So now we have some more data. So 78 kg, 170 centimeter. Roughly how much will be the BMI?
It's around 30 something.
It will be 78 divided by 1.7 divided by 1.7. So just you need to just have. So there is significant tachycardia. Okay. So tachycardia not only causes increase in demand, but reduce in supply. Okay. So how it reduce the supply?
Because the time for coronary perfusion is reduced.
How?
So that's because that cardiac cycle time is increased, so there will be less time
No,
for rest for the
not cardiac cycle time
diastolic.
is, you can
Diastolic
say
time
whenever
when
there is
pushing.
tachycardia, there is more effect on the diastolic time. Okay. And diastole is important for the coronary perfusion. So whenever there is tachycardia, it affects more on the diastolic time rather than the systolic time. So diastole is more affected, so the supply is decreased, and increase in heart rate will also cause increased contractility. So increased heart rate will
Demand.
increase the demand. Okay, so just think about other factors for demand and supply, like sympathetic stimulation, high afterload. These factors will increase the requirement, and like vessel diameter, basal requirement, and tachycardia, and this what pressure it is, Mm, left ventricular and diastolic pressure will tell the baseline requirement. I forgot there is one more point about the requirement. Okay, so here any positive? Remember one thing, this creatinine, uh, because usually in our part of world we are using milligram per DL. So, but this is the SI unit, millimole or micromole for creatinine. So you have to divide it by 88 for creatinine. Okay, so it will be around more than, you can say it's around um, 1.3 or 1.4 milligram per DL. So it's high creatinine. Okay. Uh, a little bit of hypokalemia. Okay. What else? Okay. So blood sugar, hematocrit is normal. Sorry, hematocrit is slightly low. Can you interpret between these values? Hemoglobin is 11.3 and hematocrit is 24. Is it correct? So
No,
whom you should believe, this hematocrit or hemoglobin?
Hematocrit. You should believe the hematocrit.
So what
This
should be
could
the
be because
corrected
of
hemoglobin? What should be in this, if you have this data, what is the correct hemoglobin?
yeah, yes,
You will divide hematocrit by
3.
3. So the actual hemoglobin is 8. And you will say this is hemo concentrated. So patient is volume depleted. So you need to give some volume. And if you will give the volume, the patient will have the correct, like if you correct the dehydration, so the actual hemoglobin is actually 8. Okay. Mm, platelets are okay. INR is okay. Okay, let's have some comment on this X-ray. These are artifacts. This is, what is this? Actually, I'm not sure you are seeing my point or not. This is CVP. Okay. And then what will you say? There is bilateral opacities in almost all the lung field, more in the lower lung fields. Okay. What else? Mm,
mediastinum looks wide.
huh?
Mediastinum looks wide.
Wider radius.
Mediastinum looks wide. Very good. Is it, what do you think? Is it AP or PA?
AP view.
I
APV.
think.
And because the patient most probably is lying flat. Okay. So actually you cannot comment very nicely. So it's a typical post-operative X-ray. Okay. What about the ECG? So whenever you find ECG and you need to find something, you have to go for the same algorithm, rate, rhythm, axis
Sinus
deviation,
tachycardia.
any block, any changes in P wave, QRS complex, QT interval, and PR interval. So any changes with reference to any electrolyte. Okay. So from the data which we have, it doesn't seem to have hypokalemia because there was only one finding of hypokalemia. Yes, there is like a patient is having low hemoglobin, so tachycardia may be that reason. So there is tachycardia, but do you think the rhythm is normal?
Sinus arrhythmia. No, there is arrhythmia.
Sir, it's irregularly irregular.
Arrhythmia.
Irregular. So just try to find P waves. Can you find P waves?
No.
There is no regular P wave. Okay.
Mm.
In most of the rhythm,
Block.
you will not find. So rate is around 150. It was told in the data it's around 120, but you can see that it's here. It's because the rhythm is not good. So you can say that the heart rate is more than 100 at least in the ECG as well. And this is actually atrial fibrillation. Okay. So summarize, that's what we were trying to do. Hypertension, ischemic heart disease, recovering in PACU, following triple A, develop hypotension and hypoxia at 24 hours post or following tracheal extubation. His biochemistry results suggest impaired renal function and hypokalemia. Okay. So differential diagnosis, post-operative hypotension and hypoxia in the patient can be listed systemically as follows, like myocardial infarction, left ventricular failure, as I was telling you. Okay, that cold peripheries with these things, this is poor LV function. Okay, congestive heart failure, yes, but at least poor LV we can be sure. Okay. Uh, what clinical data can predispose to CCF in this patient? Just think, which we were discussing. There was one data because of smoking. There may be COPD. So COPD with left ventricular failure with some pulmonary hypertension. This is the picture of CCF. Am I right?
Yes.
Okay. So similarly, they did not mention about the blood transfusion, but most probably, if there is 1.2 liters of blood loss, maybe the patient receive blood transfusions. So similarly, post-operative embolism is common in such patients. Okay, so pleural effusion, pneumothorax. Pneumothorax, I'm not sure how they have written pneumothorax. At least in X-ray, there was no finding. But and they have mentioned bilateral equal chest air entry with crackle. So pneumothorax, I doubt about pneumothorax. Anyways, so transfusion related acute lung injury with reference to blood transfusion. So electrolyte imbalance is one of them. Then sepsis. Uh, Sepsis markers, recently, like few years ago, they changed the simple criteria of they before they used to have SOFA scoring, so they change it to Q SOFA. It does not need any laboratory investigation. So whenever you find some of the changes in the systemic response, they try to treat in the level of in the direction of sepsis, and then they do further investigation to see the situation. High level of epidural block. This may be a cause of hypotension. Okay. So abnormal atrial fibrillation as the rhythm is regular with absent P waves and the heart rate is approximately 120 per minute. There is left ventricular hypertrophy and left axis suggesting, okay, I cannot appreciate left axis deviation, or I'm not very good in ECG, by the way. Can anyone tell how they are saying left axis deviation?
Sir, actually,
Lead
QRS is
one or
upward.
lead three rotation. Lead one, lead
Lead
three rotation.
one.
Lead
AV.
one
They
and
are
lead.
opposite to each other. Yeah, the QRS complexes are opposite to each other, then this is left axis deviation.
So what we do, the rule of thumb, am I right?
मैं तो सिर्फ इतना ही याद रखा हूँ
Okay.
मैं
So they are telling about this thing. Okay, so causes of atrial fibrillation. There are some cardiac causes and some non-cardiac causes. So cardiac causes ischemic heart disease, mitral valve disease, one of the common, hypertension and cardiomyopathy. Okay, heart failure. Then non-cardiac causes hypoxia, hypovolemia, sepsis, electrolyte disturbance like potassium, magnesium, phosphate, and thromboembolism, thyrotoxicosis. Okay, thyrotoxicosis should be not in the last; it should be one of the is one of the leading non-cardiac cause. So cause of atrial fibrillation likely to be ischemic heart disease, pneumonia, and electrolyte imbalance, low potassium. So what will you do? As we discussed before, any critical situation, airway, breathing, circulation. Okay, ECG, blood pressure, pulse oximetry, correct any precipitating factors wherever possible, any electrolyte imbalance, any hypoxia, any hypercarbia, any acidosis. You will prop up the patient. You will like this in this way determine if the patient is stable or not. If unstable, DC cardioversion. Okay, if there is no response, amiodarone administered over 10 to 20 minutes and shock repeated if needed, followed by amiodarone 900 milligram over 24 hours. This is the normal ACLS guidelines as well. In stable patient, the rate should be controlled with a beta blocker, okay, or digoxin administered intravenously. Digoxin, um, whenever digoxin has a narrow therapeutic index, so you need to monitor the electrolytes and like you will load like digoxin. I have never used, by the way, in acute setting. Maybe it's I've only seen patient taking oral digoxin. Anyways, you should be knowing
Sir, which
about.
beta blocker we can use, sir? Cardiac
I'm sorry.
specific.
Sorry.
Sir, which beta blocker we have to use? Beta one, beta
Cardioselective.
one,
Cardioselective. Relatively, there
cardiac
is no pure cardioselective, but in this scenario, you will try to have
plasminogen.
cardioselective plus with the, I think, like any beta blocker, because if you have already heart failure, so beta blocker need to be I don't remember which beta blocker has, but there are some beta blocker with intrinsic sympathomimetic activity. That beta blocker will be of choice. I don't remember exactly which one has this activity, but it is the word which I can just recall from my previous bookish knowledge. Okay. If the onset of atrial fibrillation is within 48 hours, consider amiodarone over administered by 900, and you have to rule out clot. Okay. Uh, any atrial thrombus through echo. In general, patients who have been in AF for more than 48 hours should not be treated by cardioversion until they have been fully anticoagulated for at least 3 weeks or unless T to rule out atrial thrombus. Okay. Okay. So these are signs of poor circulation or instability, or reduced level of consciousness, chest pain, systolic blood pressure less than 90, and heart failure. So signs are
Sir, it's
common.
Petrol.
Sorry, acebutolol, am I right? The one which I was telling. Okay. So IV via peripheral venous access, maximum concentration is 40 millimole per liter over 4 to 6 hours. So usually it's 10 milliequivalent per hour. This is what we usually use. Okay. When while central, you can give it relatively faster. Okay. Recheck plasma potassium at least hourly during the rapid replacement phase. Actually, potassium should not be replaced very fast. Okay. Magnesium should also be corrected whenever you are trying to correct potassium. So that's what they have told as well. 5 gram of magnesium sulfate should be administered intravenously over 20 minutes. This is too much dose. I am not sure what recommendation it is if you want to correct simultaneously. It's always practically it's always better to use a smaller dose. And whenever you are giving magnesium, you should make sure patient has urine output. Don't give magnesium if the patient does not have urine output. Plus, magnesium, you have to monitor deep tendon reflexes. You have to monitor through arrhythmias. You have to monitor through respiratory insufficiency. You have to monitor through like if you are starting therapeutically and electively, it's better that you send the blood levels of magnesium before starting. You can send the levels and then you can monitor. There are actually three units: millimole, milliequivalent, and milligram per DL. And if I'm not wrong, millimole, the double values for milliequivalent and double value for milligram. So it's like that. So you should be knowing the levels in SI units or the prevalent units being used in your setup. But you should remember the units because it's very confusing for magnesium. Okay. So okay, so neuromuscular blocking effects will be prolonged. So you see, the effects are essentially those of a calcium channel blocker combined with a membrane stabilizer. Magnesium binds to many calcium binding sites and therefore blocks the effect of calcium in a number of enzyme systems. Serum concentration of at least 2 millimole per liter is necessary to produce clinical effects. Okay, so less than 5 millimole, delayed intraventricular prolonged QT, more than 5 AV blocks, and more than 12 asystole. Hypotension can occur because it's venous venodilator. It's causing vasodilatation. Okay. Uh, Hypermagnesium does not really produce a profound reduction in it causes high vasodilatation. Okay, it's being used as a like membrane stabilizing effect, so that's why it also helps in controlling or preventing fits as we use it in preeclampsia eclampsia patient. So
Bronchial asthma, sir.
yes, like resistant bronchial asthma as well. Okay. uh, Okay, so hypermagnesemia will be treated with calcium gluconate. Okay, so if it happens, any signs of magnesium toxicity, uh, hypoventilation,
Oh,
or as I told you, arrhythmias. And by the way, hypermagnesemia does not cause decreased urine output. Decreased urine output can cause hypermagnesemia. Magnesium does not affect urine output. So it's a concept you should understand that you monitor the urine output, because if urine output is not there, there may be significant hypermagnesemia. So it's like that. Okay, but rather this neuromuscular effect occurs because of its anti-calcium effect. Okay, so this is the theory. Stable with no evidence of respiratory depression reflexes are simply observed for further symptoms and maintain urine output. If there are signs of severe systemic effect, the magnesium can be antagonized by calcium gluconate. In life-threatening complications or in patients with renal impairment, magnesium excretion may also be increased by dialysis with magnesium-free dialysate, or even diuresed. Okay, so these were the findings in the X-ray. The signs of congestive cardiac failure, hilar congestion, upper lobe diversion of blood vessels, their central line via, as I told you, by the right internal jugular vein, which is correctly positioned. There is haziness at both costophrenic and okay. What will you do? The same which we were discussing in our previous discussion about critical incidents. So the same thing apply here. So head up, prop up, 100% oxygen, and you are giving some morphine. Yesterday we were having some debate about whether we should use morphine in pulmonary edema or not. Anyways, so this relieves anxiety and pain and also produces transient venodilatation and reduces myocardial oxygen demand because of decrease in venous like because of its venodilation effect. So administer 40 to 80 milligrams furosemide. This produces transient venodilation and subsequent diuresis. Check blood gases, CPAP with CPAP, or you can say BiPAP. Invasive ventilation by reintubation if needed. Monitor the patient in a in an ICU environment. Monitor CVP, invasive blood pressure, cardiac output, fluid balance, electrolyte imbalance. So after 2 hours of resuscitation, the urine output has fallen to 10 mmol over the past 2 hours, CBP, now they are telling the next step. So BP is maintained at a mean arterial pressure of 80 to 90. The heart rate is 90. There is sinus rhythm. So now there is decrease in urine output. So renal failure, causes of renal failure in such patient. So renal hyperperfusion, blood loss, hypovolemia, cardiac failure, renal artery stenosis, and due to decreased renal perfusion, result of increased abdominal pressure, abdominal compartment syndrome. Okay, because abdominal compartment syndrome, by definition, is development of new organ dysfunction with increased abdominal pressure. So that is abdominal compartment syndrome. Okay, so renal causes will be use of this NSAIDs and uh, glomerulonephritis, amyloidosis, diabetes is a risk factor. Nearly 90% of intrinsic AKI are caused by ischemia or toxin, both of which lead to ATN. Ischemic acute renal failure is associated with reduced blood flow to the kidney, renal hyperperfusion, which leads to tissue death. Like, that's why if a patient with renal risk, mild renal impairment, you give NSAIDs, yeah, and you keep the patient hypoperfused and hypotensive, so the patient will be at risk of development of renal failure. Similarly, you see, NSAIDs, they have the aminoglycosides, antivirals, and dyes. Okay, so they will also those cause, and any crush injury or any prolonged actually surgery with the like use of tourniquet. These are all risk factors which can lead to further deterioration. Okay. Post-renal is the obstruction caused of obstruction in urinary collection, such as bladder, due to an enlarged prostate or bladder stone. Okay, and because we just short of time, we have to finish the discussion. They will just tell few points about abdominal compartment syndrome. Renal failure with an elevated intra-abdominal pressure is multifactorial. There are decrease in renal plasma flow and GFR and increase in renal vascular resistance, which may lead to urine output and subsequent AKI. So this is what happens in such patients. So magnesium we have already discussed. You can just have, this is actually the magnesium replacement therapy. And abdominal compartment syndrome actually is a separate topic. So, but usually is an increased abdominal pressure with organ dysfunction, as I mentioned to you. Around pressure more than 25 leads to respiratory, cardiovascular, and renal dysfunction. Respiratory, because abdomen diaphragm will be pushed and there will be problem in respiration. Cardiovascular, by aortic valve compression, and renal dysfunction with renal hypoperfusion. Okay, so prompt recognition and management of abdominal decompression and fluid resuscitation is likely to improve the prognosis. Okay. Severe penetrating and blunt abdominal trauma. These are the risk factor for ACS, acute abdominal compartment syndrome, ruptured abdominal aortic aneurysm, retroperitoneal hemorrhage, pneumoperitoneum, as occurs iatrogenic in laparoscopic surgeries, neoplasm, pancreatitis. Okay, so either it is decrease in venous return, compression of inferior vena cava causing a reduced venous return, as I told you. Increase is after low direct compression of blood vessels and vascular bed. Changes in ventricular compliance, diaphragmatic elevation, which causes distortion of ventricular compliance. So all these factors contribute. So treatment of it is uh, transmission of IAP to the vena cava and vascular causes in increase in CVP and pulmonary artery occlusion pressure, and hence are not good indicator in fluid resuscitation. That's why it is important to have in like invasive blood pressure monitoring or cardiac output monitoring, because simple CVP will not be a good indicator. Okay, so they have just told what changes occur with reference to FRC and TLC, and vascular resistance increases due to hypoxia and increase in management direct. Okay, so this is another question, that how to monitor. So either it is directly measured through laparoscopy or through the bladder. Usually it is done with the bladder, full bladder, and they put like a pressure transducer in measurement of intravesical pressure via Foley's. This is the 4 stages which we have mentioned. So actually, this is extra portion of it. This is what I just try to give you a vision, because we just have a lot of lateral thinking. So my suggestion to you, even yes, of course, my aim was to give some vision for the people going for oral exam. But remember one thing: make your habit to study like that, because you see, in this one scenario, how many things we have just jolted our brain. Our brain must be angry with us at the moment, because so many things, so many, like a sitting like in a roller coaster of knowledge. Okay. So thank you very much. So we will meet again tomorrow, inshallah. Tomorrow, I'm not sure whether I will be able to take it or I'm on call. If I am free, I will. Okay. So thank you very much. Bye bye.
Thank you, sir. So nice of you.
Okay, my dear. Thank you. Bye bye.